My name is Matt Jansen. I'm the Executive Director for Georgia Partnership for Telehealth. I've been working with GPT for several years on growing a statewide network that is facilitating a lot of access to our rural communities, filling in the gaps that we're seeing in some of our healthcare areas right now. Today, what we wanted to focus on was telepsychiatry and how it's impacting our state and how it's actually being provided by the provider, hearing it from the provider themselves. So I brought in a couple experts that are in our network that are actually providing a very, very extensive list of services throughout our network. And so what I want to do is briefly tell you a little bit about GPT, Georgia Partnership for Telehealth, and what we've been doing. And then I'm going to turn it over to Mike Coleman and Dr. Michael Burke and have them kind of give you a little oversight of what they're doing at United Psychology Center. So right now, with Georgia Partnership for Telehealth, we were started in 2007. We have since grown to over 500 endpoints. We roughly have over 180 physicians in our network, representing over 33 specialties. We are connected to lots of different types of environments, everything from hospital systems to nursing homes to schools to non-traditional, traditional clinics. Now we're starting to move into, of course, community health, community mental health. We have some exciting things coming up. So this is going to be one of a couple series of webinars that we're going to be doing with Healthcare Georgia Foundation. And I want to thank them again for allowing us to come on and talk to you a little bit more about what telemedicine and telehealth is doing in the state of Georgia. And then also I want to thank TechBridge for also providing a really unique resource to our state, to some of the nonprofits out there that need assistance with technology, especially in small organizations. So right now, I just want to turn it over to UPC and their team. And right here, I've got Mike Coleman. I'll turn it over to you, Mike, and have you give a little bit of your background and what's been going on at UPC.
Well, my background is largely clinical, more in counseling. I'm the executive director at UPC. We started off as more of a brick-and-mortar, traditional type practice. But over time, we seen that there was such a huge need for rural communities to be covered with psychiatric treatment, with other modalities of treatment as well. So we kind of put our heads together, and that's when I met Dr. Michael Burke. And since that time, we've kind of, turned into more of a full-time telepsych practice as opposed to a traditional practice. It's been nothing short of phenomenal what we've seen and what we've been able to really accomplish to that end.
Dr. Burke.
And I got involved. I had more than 20 years as an academic psychiatrist, had been doing a number of sort of interesting and cutting-edge kinds of treatments, everything from working as a psychiatrist within a cancer clinic, having one of the first ACT teams in the VA hospital, having had a chance to work with homeless vets, even some cutting-edge psychopharmacology research and other research that I had a chance to do. And I also have always been interested in trying to help underserved populations, basically helping patients who have a hard time accessing health care with the opportunities to get that health care. And that's been a real problem for psychiatric patients in general, but a very difficult problem for patients who are in rural areas, as if you look at the data and you see where psychiatrists and other mental health are located, places in Georgia have huge swaths of land where there's no mental health at all, and when looked at, are highly underserved. So this was an opportunity that I was excited about on the application of a new technology, as well as this opportunity to provide these underserved populations for healthcare. So I said, let's see how this goes.
So getting into your experiences and what you're doing right now in your practice, tell us a little bit about the patient and how they're reacting to your, to this maybe some of them have had some experience with telemedicine, but sometimes this is their first time actually experiencing something like this, or actually even having access to a psychiatrist. So can you walk us through some of the kind of experiences you've had with patients and some of their responses?
Sure, absolutely. I think that initially there was a lot of questions, even from folks within the office and people that I know. It's like, well, what's this going to be like? I'm like, not sure yet, but every different kind of treatment has always been met with, what's this going to be like? You look at a sort of community treatment teams where you actually went out to the community and went into the patient's homes or group homes or those kinds of things. And there were, initially, we had a lot of mental health professionals and psychiatrists who said, this can't work, this is going to be unreasonable, something's going to too intrusive or change boundaries, it's going to be a challenge. And what we found is that it's a very effective kind of treatment. So I was looking forward to seeing how this was going to work. And remarkably, most patients take to it pretty quickly. The response sometimes is, wow, am I supposed to just talk? And it's like, yeah, you got the physician on the other side who can see you just like you can see them. Just go ahead and talk naturally. And once you start to have that conversation and initially do that, it really works flawlessly. You get a couple of patients, and we've had some. We even had one who came in initially, and he was like, I'm not talking to any computer. I'm not talking to some faraway doctor. And I just kind of said, well, just tell me a little bit about things, and then we'll let you go right away. Honestly, after about 10 minutes, and Mike was helping me at the time.
45 minutes later, he's still there talking.
Yeah.
So he adapted well.
He not only adapted well, but apparently he had really never had an opportunity to sit down and talk with somebody much. And by the end, we were really recommending to him that he needed an opportunity to continue to use services because he had a lot of old grief issues. And so in some ways, just like anything, if you are uncomfortable with dealing with your issues at first, it's using whatever it is that's available to say this is a barrier. I don't like talking too close, too far, on a computer, on a phone. But as the technology that we've discovered, if there's good bandwidth on both sides, we find that it's pretty amazing as to how quickly it is that people adapt and that we can have a normal psychiatric session.
Yeah, so creating a standard or a healthcare environment, you don't want to, you really can't cut, corners in some areas, in relation to bandwidth, in relation to making sure that you have a real face-to-face, as close to face-to-face encounter as you can. So you want to talk a little bit about that?
I was going to say some of the issues that, and I know Dr. Burke can speak to this as well, but some of the issues were at some sites the bandwidth would not be as strong.
Yeah.
So you would have cutting out every fourth, every fifth statement.
Yeah.
So from a clinician standpoint, you're sitting there and you're trying to listen, but you're missing that key piece of information. And you don't want to go back and say, excuse me, over and over and over. That's why it's so important to get a high speed type capacity.
Although even in those circumstances, and one of the things that I've been surprised at is, just like any other kind of situation, if you introduce it right, this is something that, both of us might have a statement cut out or something else. I often, the first thing I do is I tell them, don't be embarrassed to interrupt, to tell me you didn't hear anything, something else like that. And I'm going to do the same.
Yeah.
And patients remarkably get used to that, to the point where, we've seen patients in all different kinds of settings. And in the process of those settings have had good sessions, everything from, regular offices for either psychologists or internal medicine offices. We've seen people, all the way to the point where they've taken one of the devices with the screen and everything else and tilted it right up to a patient who was in an ICU bed. And, we did face-to-face for this with the ICU bed. And the patient, this was a rural hospital, didn't have any not only not have a psychiatrist, but I'm board certified in psychosomatics, so that I have done lots of care for these kinds of patients, and in general hospitals, and it was something where they were able to get a service and a specialist that they otherwise wouldn't be able to get easily.
Yeah, so let's take that, and so from your traditional experience working in hospitals and from a bricks and mortar clinic, practice that you were running or prior to this, explain a little bit maybe some of the differences and how the theory behind those things are in your mind were running, and now how they're running in practicality, and are they close, or